So, John, you may perhaps begin and introduce your colleagues as well.
Okay. Thank you, Jatine. Thank you for having us to speak about our project. I'm joined by three of my colleagues, Reem Mula and Bonaventure Egbujie and Brittany Kroetsch. All of them have had the pleasure or the suffering of doing PhDs with me and are active collaborators in this project as well. What we'll do is I'll give a quick overview of the project, and then I'll call on Bon, Reem, and Brittany to answer questions about their engagement in the project or issues about the countries that they're working with. So Bon has been our lead in Nigeria, Brittany our lead in Uganda, and Reem in Sudan and Egypt in terms of this project. This project is called the PANOS project, or the Pan-African Utilization of Lay Assessment Systems. It's a project focused on community-based primary care for older adults in Africa. And as part of our INTRI research group, all of us are affiliated with INTRI. INTRI is a non-for-profit network of about 140 different clinicians and researchers and policy experts. We've been doing this type of research for over 30 years. We develop assessment systems to assess strengths and preferences and needs of vulnerable people through a very active multinational program of research where we design these systems, we gather data as part of normal clinical practice, and we use those data to inform decision-making at the clinical and policy levels. These are the organizations or countries that have been involved in INTRI so far. The blue text are countries where there's a formal fellow from that country. In green is where we do not yet have a fellow, but we're actively involved in research in that jurisdiction. INTRI really started as a North American and European collaborative, and we've always had constraints in reaching low and middle income nations for reasons that'll be clear as this presentation goes along. In Canada, these INTRI assessment systems are now widely used across the country. In fact, every province and territory except for Quebec and Nunavut have mandated at least one of our assessment systems. So to date, over 23 million assessments have been done on over 6 million unique Canadians. All of you who live in any of these provinces will know multiple people who've been assessed with INTRI instruments, whether it's in the home care, long-term care, or mental health sectors. But we've been interested in population aging for a number of reasons. One is that Africa is now going to be the fastest aging jurisdiction or continent in the world, so that we're going to see a tripling of the raw number of older adults in Africa, and over 2/3 of African nations will have over 1 million older adults in their population. But the countries really aren't prepared for that rate of population aging. Reem and Bon can both tell you about their medical training in Africa that they received, where they got very little to no geriatric medicine training. And older adults are complicated in terms of their health for a variety of reasons. I mean, medical conditions, complex, multiple medical conditions can be a challenge, and stress and environmental factors and poverty and disability can all be important interacting factors. Many of them will have higher prevalence rates in African countries. And then if you have a medical system that isn't well equipped to respond to the needs of older adults, the risk of medical errors goes up. Now, a standard approach to dealing with older adults is comprehensive geriatric assessment. In fact, WHO says that all countries in the world, as part of the Decade for Healthy Aging, should have a mechanism for comprehensive annual checkups of the health and social needs of adults aged 60 plus. So their criterion is everybody has to do this. The challenge is health human resources. So this shows the supply of physicians and nurses per capita compared to Canada and the United States. So South Africa is by far the wealthiest country in terms of health human resources, but you can see a country like Malawi has almost no physicians or nurses for the population. And if we were to think about a massive training program to triple the health human resources in these countries, they would not first be allocated to care of older people. They would probably sort of focus on other aspects of population health. So a solution that we've been exploring is the use of lay health assessors. This started in South Africa, in the Cape Town area, in Khayelitsha, an informal community to north, and several other communities. This was done in Momry near Cape Town. And what we're doing is we're training lay health assessors to use a standardized self-reported assessment tool that we've created. So the people that are in the photo are some of our assessors. One is a retired factory supervisor, another is a retired librarian, another one is a retired accountant. All of them have good literacy skills, all of them have good interpersonal skills, and all of them have respect in their community, but they have no medical training per se. So we funded this first project with grant funding from the University of Waterloo, from Waterloo International, and from the Introi Group. We got a industry partner to provide additional funding. The total funding for this project was 120,000 US dollars. That's what we got for the first phase. And what we wanted to do was demonstrate feasibility and acceptability, work with a variety of different types of clinics, establish a leadership team, and establish the credibility of our network for being able to move on to larger funding. These are the countries that we got involved. So all the countries that do not have an underline in them have contributed to the study. So we're already in 14 countries, and we have several others that are coming into the mix. I need your help to find somebody in Namibia to work with. The reason it's important is I was born in Namibia in the 1960s, and I have to be able to get my birthplace involved in the study. We have tried and tried and have struck out in Namibia. So if you have connections, help. My emotional well-being depends on being able to go back to my roots. You'll notice we had Sudan in it before the Civil War. Reem coordinated that, and the people doing the inter-eye checkups there actually had to retrieve paper copies of it from homes that were later bombed. So it was under heroic conditions that they were able to pull that project off. So we have a large multinational team, a multidisciplinary team of researchers, clinicians from all these different countries involved in this. We've translated the assessment into all these African languages. And we have data. So we have over 7,000 observations now from all of these countries. We didn't have sort of aim for perfect random sampling, but we sort of looked at who their typical populations in these different clinical settings. Some countries did door-to-door surveys. Others did primary care clinics. Others had specialty programs, like Brittany's working with an HIV program for older adults in these different countries. And you can see we have different age ranges represented. Some of the samples are older samples. Poverty is an important issue, but it varies. So interestingly, a small proportion of people in Malawi say they're making economic trade-offs, but in Sudan and Tanzania, for example, the rates are very high, as they are in Egypt. Diagnoses are quite variable. You see some diagnoses are rare in some countries, very prevalent in others. We're very confident that underdiagnosis happens because people don't have access to a physician to make a diagnosis. But if you look at ratings of their self-reported health, you also see variability where, in some cases, only about less than 10% of the sample are saying their health is excellent, but in some of the door-to-door samples, more people in good health. These are our clinical scales that we derive from the assessment. So we can measure mood disturbance, pain, medical complexity. The CHESS scale is a measure of frailty and instability in health. It's very predictive of mortality risk. So a person with a score of 3 on the CHESS scale has a moderately elevated risk of mortality. A 5 are people who probably are going to die in the next 90 to 180 days. And again, you see we picked up variable samples in these different settings. And we have other clinical scales that describe cognition, IEDL impairment, or high-level functioning, basic measures of disability, which again vary across these groups. The key thing for us was to establish the measurement properties for this. So to measure reliability of scales, you use something called Cronbach's alpha. A Cronbach's alpha score of 0.7 is acceptable, 0.8 is very good. These are the Cronbach alpha scores across all these different jurisdictions, and you can see it's very good performance. In fact, case managers in home care in Ontario get similar Cronbach's alpha scores. So in these settings where we're using non-health professionals, we're getting comparably reliable measures of mood disturbance and 2 measures of disability. And then if we look at the patterns of associations between different variables from a validity point of view, we know that mood disturbance, pain, medical complexity are associated with a person's perceptions of their health. And you can see across these settings, for the most part, you get a similar magnitude and direction of associations. None of this is going to get any of us awards in terms of, breakthroughs. This is just showing that the data are working the way they should work, that mood and pain and mood and depression hang together, cognitive impairment and disability are also working together. So what we've been able to do with this project is to show that in very poor nations, we've been able to, in a feasible way, gather these data in about a year and a half time frame is when the study was done. And so we now are looking to expand this project. We've demonstrated that it's doable, that we get good quality data, and that it generates data that are clinically actionable. All those clinical scales are extensively validated through previous inter-eye research. We're working to expand to other African nations. So Reem is working with Morocco and Tunisia and Sierra Leone to bring them into our network. We've established the relationships, have a credible group. Each of these sites contributed at least 300 cases per site. Some are now moving to a longitudinal version of their study. We have local implementations happening in Uganda, Malawi, and Nigeria. So Bon can tell you about the HIV program that he's working with, and Brittany, if you could talk about the Uganda project as well. And we brought inter-eye fellows into the international network from these different countries. So we now have an African leadership team that's working with us. We are bringing in additional partners. So the African CDC, we have links to WHO and Red Cross and Salvation Army, but we'd like your suggestions of others that we can connect to. And we're now at the point that we're ready to go from a pilot study and feasibility to scale up first to longitudinal studies where we can establish mechanisms for follow-up. And then we want to move on to interventions studies to ultimately establish communities of practice in primary care, because we'll establish a common data standard that can be used to evaluate the quality of care. And we're also looking at educational interventions to use this effort as a mechanism for doing geriatric training in the African context. So with that, I'll stop and maybe ask Bon if you could describe the training that you've done in Nigeria and the HIV program that you've done, and perhaps Brittany, if you could talk about your Ugandan project, and Reem about the work you've been doing in Sudan and elsewhere. So Bon, if you could start, I'm going to stop the screen sharing at this point so everybody can see each other.
Yeah, thank you, John, and thank you for the opportunity to talk to the group. I must say that it's been an eye-opener for me to be part of the POLAS project. And like John mentioned, I'm actually still in Nigeria, where I conducted a training for healthcare workers, doctors, nurses, who are being supported by the PEPFAR money from the United States to essentially look after people living with HIV. So through the knowledge that we obtained implementing POLAS for the general population, we found that it was important to also target people living with HIV who are themselves getting older. So when I had this training last week, one of the themes that kept recurring was that people were not really primed to manage the older adult. Because what I was hearing was that we didn't know that this is what aging is about. And these are doctors. These are not lay people. These are people that were trained as doctors like me. What they thought aging was diabetes, hypertension, the usual non-communicable diseases. But people didn't think much about the physical function, the ADL, the IADL, the CPS. So using the product that were generated from the checkup tool that we're now implementing to POLAS, people were able to see that the older adults is more than just those single diseases, and it was very well received. And people kept saying, oh, this is new. And this is not just for the site we're working. As someone who grew up in this society, who trained here, I know this applies all across board. So it's really a very good project that we're doing. It's well received. And it's not only well received, it's going to make an impact, because we now have data from 2 assessments. They are now beginning to do the second assessment. And you can already see that for some people, it's an improvement just because they know that this thing is going on. The healthcare workers telling them that this is going on. some things are beginning to change. So it's really been a very good engagement so far.
Great. Thank you, Bon. And Brittany, could you describe a little bit about the HIV program you're involved in Uganda, where you've been using this?
Yeah, good morning, everyone. And yeah, thank you for welcoming me to this talk today. So I work primarily with two nonprofits in Uganda. The first is a community-based HIV organization that supports people living with and affected by HIV in the community. They have a specific program that targets older adults within that program. So it's called the Grandmothers Project, and they partner with multiple nonprofits in the area. So for my master's work, we actually, this was pre-Polis, we implemented the checkup assessment to really determine whether it was actually feasible and acceptable to be used in that community with that population, specifically with older persons living with HIV. That project was extremely successful, similar to the Polis project that John has just described. We did interviews with all of the healthcare providers, the administrative persons that were involved in the implementation. And I'll kind of highlight again what Bon said about the positive kind of the perception about what we were actually doing. And there was a really big lack of knowledge about the actual needs of older persons in the community, and a huge gap in knowledge about, what are the actual conditions that this population are dealing with. Lack of understanding about things like dementia and Alzheimer's and cognitive impairment, functional decline. So it was a really good opportunity to kind of equip not just the lay people that were doing these assessments, but also the folks that were actually supporting older adults in the community with more knowledge about kind of what's going on with this population and how can we support them. I'll say too that it was a really positive response from the older persons in the community as well. They were really excited to actually have the opportunity to be assessed and to have someone interested in their care and in kind of their overall health. So it was an assessment that typically takes 30 minutes was taking closer to an hour or more, because they were just so excited to be able to kind of talk about their needs. I'll stop there and yeah.
Yeah, and so Reem, if you could say a little bit about your training when you were a medical student and the work that you've been doing in the North African countries.
Yeah, thank you very much, John, and thank you everyone for having me today, and thank you for this opportunity. So yes, as I will echo, what Bon said. As for me as a physician, having been trained in Sudan, we did not have the any training, as a matter of fact, about older adults or geriatrics. So I've been always advocating for older adults and went to the Minister of Health back then, and that was in 2018, because I wanted to take the initiative for improving healthcare services for older adults. And to my surprise, he was like, they are not the priority. So we have more priority, not only non-communicable diseases, but because Sudan is an endemic area for many infectious diseases, as schistosomiasis or malaria, cholera, for instance. And so that was their main focus. So yeah, after I've done my PhD, joined John's group, and finished my PhD. I've discussed the findings from the Polis project with some of the officials there, and it was an eye-opener, because to them, they weren't aware of the problems that the older adults are faced with. So I think it's a very good opportunity for Northern African countries.
Thank you.